There you go. Hello, everyone, and welcome to the breakout session entitled When Language Gets Lost, Finding Your Way Through Primary Progressive Aphasia. My name is Arinda McIntyre, and I'm a volunteer member of the Rocky Mountain Conference on Dementia Planning Committee and a community educator. I'm also a pharmacist and technical product manager for Wolters Kluwer Health. I'm pleased to be joined today by Stephanie Barnard, who will be presenting this session. I'll be back at the end to help with moderating questions, so please type them in the chat as we go along. Let me take a moment to introduce Stephanie. Stephanie is a certified speech language pathologist. She earned her master's degree at Portland State University. She has extensive experience with various speech, language, cognitive, and swallowing disorders, including aphasia, dysarthria, apraxia, dysphagia, cognitive communication, and expressive receptive language impairments. She now specializes in aphasia at Taylor Neurospecialists. Compassion, understanding, and creativity are the foundation for her approach to a productive and meaningful therapeutic experience for patients and families. Stephanie is a certified Speak Out provider, which is a program to increase speech intelligibility and volume for those with Parkinson's disease. She has 7 years of experience co-facilitating the Alzheimer's Association Frontotemporal Dementia and Primary Progressive Aphasia Caregiver Support Group in her area. And in her free time, she enjoys cycling, hiking, kayaking, and stand-up paddleboarding. Stephanie, the stage is yours.
Thank you, Arinda, and thanks everybody for being here today. So I'm Stephanie, and I work at a small private practice. I'm a neuro-speech pathologist. I work in Denver locally, and we have the privilege of being able to reach people all across Colorado and Arizona as well. So today I'm going to talk to you a little bit about language related to primary progressive aphasia and how we can kind of cope and work our way through that diagnosis. We've got a few objectives today. So first, I want to define what are the 3 subtypes of PPA. We're going to discuss the early, middle, and late stages of primary progressive aphasia. I'd like to offer a kind of a dual perspective. So what is it like for the person with aphasia, or the PWA, to lose communication once they've gotten this diagnosis? And also, what is that experience like for the care partner involved? We're going to talk a little bit about speech therapy and treatment options. I'd like to offer you some strategies for the communication partners, and then we'll kind of wrap up with some other things related to PPA that I'd like you to consider. Okay, let's dive in. So there's 3 subtypes of primary progressive aphasia. We've got progressive non-fluent or agrammatic PPA, logopenic, or it's also called progressive fluent, and then semantic PPA. And this chart just kind of shows you generally where the different types are going to start to occur. So the brain view that we're looking at is through the left ear, looking at that temporal lobe on the left side of the brain. So let's start with progressive or non-fluent agrammatic PPA. So what we're going to start to see is that single word meaning remains relatively intact, but longer sentences are going to start to be harder to understand. So kind of as the complexity of the language load goes up, the more difficult it's going to be for somebody to understand. One unique feature of this non-fluent PPA is something called apraxia, which is often joined with aphasia. It's a motor speech difficulty. So that something that we do automatically when we speak is our brain transmits a message to say, I want to say the word chair. I know how to move my tongue and my lips and my voice to create those sounds to say chair. But when somebody has apraxia, they're going to maybe have a miss on how to articulate that CH sound. So it might come out tear instead of chair. Having that motor planning problem is going to be present here. We're also, as the name kind of states, we're going to see some grammar problems come into the picture. So The characteristic of the language might be shorter messages, simpler phrases, maybe missing some words. The word order might get mixed up. Oftentimes, those connector words are going to start to be left out, mostly because it's effortful to get out those content words, and so the smaller words will just get left behind. So somebody might say, what doctor time, when their message really is, what time are we going to the doctor? Okay, our second type of PPA is called logopenic PPA. In this one, at least at the beginning of the diagnosis, comprehension is relatively spared, but you're going to see more difficulty with finding those content words, the ones that really carry the meaning of the message. Speech is going to flow easily for small talk, things that are kind of rote and routine, like, hi, how are you? I'm fine, thanks. Those things come out pretty automatically still. But again, for more complex language, speech is going to slow. You might describe it as halting, and it will have some stops in it. You might kind of think of it as that like tip of the tongue syndrome. I know what I want to say, I just can't find exactly the right word for it. So I went to the speech therapist, right? It's kind of that groping and working for the right content word. And for logopenic PPA, reading and writing often reflect the verbal language skills. So somebody might have more difficulty with reading a novel, but maybe reading a street sign is still preserved, right? Depends on the complexity of the task as you go through. So semantic PPA is our final type. The most notable symptom, is absolutely the reduced comprehension. That's going to be something that you're going to see in the beginning. Whereas with the other two types of PPA, comprehension it's going to decline later on in the diagnosis. But for semantic PPA, that'll be our first kind of tip off that something's happening. So the meaning of the words is going to start to be lost. We hold the written description of the word and the meaning of the word and the picture of the word all in slightly different parts of our brain. So somebody might be able to read the word, bottle, but they may not completely understand the actual meaning of it. I will say that more common words are going to be preserved longer. So that's something to keep in mind, especially if you're a communication partner, trying to kind of simplify your language so that you're using those common words, bottle versus pitcher, car versus vehicle, run versus gallop. Those simpler words will be accessed longer. So because comprehension is affected, you're going to see difficulty following directions, difficulty tracking conversations. I kind of think whether we realize it or not, our conversations tend to really jump around, right? Even if they're on somewhat of the same topic, we put jokes in, we put kind of asides to other people. They do tend to branch off significantly. So somebody with semantic PPA is going to start to really have trouble tracking all of those layers of the conversation. Another key piece of this is speech may be fluent, but it may not make a lot of sense. So when we say speech is fluent, we mean it's not described as that halting type of speech, but you're going to hear a message that doesn't make a ton of sense. Maybe something like, then we ran to the water was green for the flunder thing. And often what's happening is in that person's brain, they have a message they are trying to get out. It's just not coming out right. And there's a difficulty with recognizing that it came out wrong. So that's something that's a little bit hard to overcome sometimes. All right. So kind of in general, we have three main stages: early, middle, and late. In the early stage of PPA, kind of what would get you into the doctor and maybe like alert you that something is starting to change. These are the symptoms that you might notice. So that word finding difficulty, that's kind of unusual for normal aging. There is absolutely a within functional limits amount of word finding error that happens as we age. People always say, my friends and I are all having that kind of tip of the tongue syndrome. So we're talking about more than that, more noticeable than that. You might notice someone that has slower speech, they're mispronouncing words. Um, they might start doing something called circumlocution, meaning they're not able to get exactly on the target word like car, but they're kind of describing around it. It might be noticeable to you. So something like, oh, it's the thing that's parked outside. I drive it every day, right? It's a description of the concrete word. Again, difficulty with reading, writing, spelling, and arithmetic can come up. Those are all stored in a similar place as our language, and are all kind of types of language themselves, right? Maybe trouble following a conversation, tracking, especially as it branches off, harder to follow multiple directions, and then using shorter phrases, maybe with more simplistic language. One thing about early stage PPA is that in general, most people tend to be still quite cognitively intact. So many people with early stage PPA are still able to drive and live independently, manage finances and medications. I would always encourage somebody that has a diagnosis of PPA to get a cognitive test as a baseline. One thing that's tricky about that is that most cognitive tests are very rooted in language as the way that they test, right? You have to follow directions and name animals and answer questions. So that kind of complicates the picture of the testing. But with the right neuropsychologist or speech therapist, we can work out how to best test somebody that has an aphasia. All right, so when we move into our middle stage of PPA, the diagnosis is definitely noticeable at this point. There's more difficulty with even simple communication. You might notice someone kind of mixing up their yes and no responses, saying yes when they mean no, or vice versa. Maybe there's an increased groping for sounds. Groping just means kind of that like searching with your lips and tongue for how to make those speech sounds. Increased processing time for comprehension is probably required. Increased need for nonverbal communication, right? So pointing or kind of showing what you mean is going to come into the picture. There's definitely going to be an increased dependency on the care partner. That care partner is going to start taking on more of those high-level communication and cognitive kind of life duties. And in this middle stage, we're going to start to see a mild to moderate cognitive decline, most typically. Okay. So then we move into our late stage. At this point, we really are moving into total communication and cognitive dependence. The care partners really have to anticipate all needs. The person with aphasia no longer really has the language skills to participate in making choices for wants and needs. There's a decline in their ability to participate in ADLs or activities of daily living, and cognition is significantly impacted. So the focus here is really on safety and comfort for the person with aphasia. Okay, so I want to offer a dual perspective on what it's like to kind of have this progressive aphasia and lose communication for both people. I think it's so important to remember that while there's, one person with a diagnosis, there's another person that's experiencing a lot of loss themselves. And, we can hold empathy for both people going through that experience. Okay, so losing language for the person with aphasia. Language is, of course, helps us say that we want a turkey sandwich and not a ham sandwich, but it's so much more than that. It is such a core part of our self-identity, right? It's how we express our ideas, our beliefs, our values, our sense of humor. It's how we teach people. It's how we learn, how we experience entertainment. I mean, language is the foundation of, in my opinion, how we experience and interact with the world. So if we can just kind of take a second to think about, what it is like to lose language, you're losing a lot of self-identity and having to kind of find it in other pieces and places. So someone with this progressive aphasia might find that they're having reduced independence or satisfaction with social interactions. Making choices becomes harder, feeling like an equal in their house and in their partnership. Functioning independently, they're going to need more help and supervision as this diagnosis continues, right? We know it's progressive. And honestly, this is not a diagnosis most people know about or expect to get. Aphasia is very widespread, but unfortunately, the broader population does not know what aphasia is. And so there's also this experience of having to kind of educate people constantly. So it's this overall change in quality of life and self-identity for the person with aphasia. So what about the care partner? Right? There's a shift in the relationship dynamics. There's a variety of care partners. Maybe it's the spouse, maybe it's a parent-child relationship, maybe it's between friends. But there is a shift in someone having to maybe take on more of the language load or be more patient and kind of have to learn how to navigate through the diagnosis. Somebody might have to take on more of those life tasks. Maybe the roles were split in the house, and so the person with the diagnosis was always the finance person, and now their spouse is having to learn about their finances and really figure out how to do them independently, which doesn't even take into account kind of the time and the cognitive load that that requires for the person that's the care partner. They're going to have to learn how to slow down the pace of their own communication and daily tasks, right? Things that maybe we were able to get 10 things done in a day, and now we're having to reduce it to 5, and later on it's just 1, right? That can really impact the care partner's life as well. They're going to need to offer more assistance, more supervision. There's a component of sharing the diagnosis and how that sits in terms of comfort with being vulnerable, or maybe they're a private person or private family, but having to kind of open up and explain what's going on in their house. There's so much kind of ambiguous loss that goes with any of these degenerative diagnoses. So there's the piece of accepting the diagnosis and then constantly adjusting to the changes, right? We know it gets worse over time. So it's not just, this is the diagnosis, I understand it, and we're done here. It's constantly trying to learn what new language has been lost or what new abilities have been lost this week or this year. Very difficult to find time for self-care or time off. And that can cause increased isolation and depression for the care partner. Okay, so speech therapy and treatment. What can we do once we have a primary progressive diagnosis? So unfortunately, at this point, there is no cure or treatment to stop or slow the progression of the disease. I think when we typically think of therapy for something like a stroke or a traumatic brain injury, we think the person gets better over time with therapy. But with a degenerative disease like this, our goal is not language recovery, right? Our goal is to educate the patient and the family about the diagnosis, what does it mean, and about the prognosis, where are we going? A speech therapist works to understand the patient's communication needs, which are really vastly different. Maybe Bob wants to be able to still play golf and talk to his buddies on the golf course, and maybe Joe wants to be able to read a book to his granddaughter. Right? We're going to create and train strategies to support the current language skills. A big piece of this is trying to figure out not only what's impaired, but what's not impaired. How can we take advantage of what's still there and try to kind of keep it as robust as possible? A speech therapist will also help with counseling. There's so much grief that can happen as we move through the diagnosis and the loss. So we can kind of help navigate some of that. And I think the big piece to help families understand is that this is such a moving target, right? It's going to continue to change every time we see you. And so our job is just to help you see those changes as well and understand them and adapt to them. All right. So when we think about communication strategies, I'm going to kind of take these by stage because they're going to vary depending on if someone's in the middle, the early, middle, or late stage of the diagnosis. So communication strategies are both for the person with aphasia and for the communication partner, but the partners are going to be the ones that kind of help navigate and implement the strategies. So we have a variety of partners, right? Maybe in the home, it's the significant other, and the children are kind of living in town, but not in the house. There's friends, you're going to communicate with them differently. And then community members, right? Like a server who maybe you see once, or a caregiver, a therapist who you see twice a week. We're going to communicate with all those people a little bit differently. So we might suggest and find different strategies for each kind of a level of communication need. Okay, so early stage communication strategies. I'm going to throw a lot at you guys in the early stage because this is the time to start exploring the strategies. As we move into the middle and late stage, the strategies become less and less useful because there's more language loss and there's more cognitive loss. So now is the time in the early stage to figure out, what do we want to hone in on? These are all just suggestions. I would never suggest to anyone that we do all of these. But the biggest thing for strategies is consistency, right? I always tell my patients, therapy doesn't really make a big difference for 1 hour, the 1 hour a week that you're in my office. Where therapy really happens is out at your home or in a restaurant, is when you guys are trying out these strategies and getting more and more comfortable with them, and kind of just starting to really fold them into your life. That's the therapy. And so you picking some strategies and then committing to using them is really what's going to show a little bit of a difference in communication independence. Okay, so some things you can start with are nonverbal communications, right? Those are really easy to incorporate. Gesturing what you mean, pointing to things. You can kind of mime coffee cup, using pictures of family members to kind of, or whatever you're talking about to help elaborate. You can use technology if somebody is really struggling to understand concrete nouns or words, right? If you say, go get the ketchup from the fridge, and ketchup is just really catching them, you can say, hey Siri, show me a picture of ketchup, and show them the picture of the ketchup, right? Even if you're sitting at the dining room table and they're at the fridge. So you can use technology to kind of help you clarify. I'm going to say till I'm blue in the face that we all need to slow down when we're talking to someone with aphasia. Processing is a little slower. We just, I think, all tend to speak too fast. So getting comfortable as the care partner in just slowing your pace and taking it easy is going to be a really huge help to someone with aphasia. When we think about educating people kind of on that second tier level, right, like friends or community members, I always suggest just make a script and practice it, or even have just a little card that has your script on it. Joe has primary progressive aphasia. That means that it's hard for him to speak and understand. Please be patient with us, something like that. You can write a letter to your neighbors, just something to help you kind of explain it so that you're not always having to kind of come up with that new on your own. You can label items around the house, especially if reading is a strength still. And then you can create, practice, and implement the use of communication devices, which we're going to talk about right now. Okay, so what's a communication device or a communication board? These are some examples on the bottom here of a variety of kind of complexity. So we can have them be simple or complex. So one of my favorite go-tos, especially in the clinic room, is just the whiteboard, right? Being able to write down my message to clarify, or if somebody's really kind of groping for the sounds or struggling, I'll write down what I think they're talking about and ask, are you talking about your new car? And it gives them an opportunity to say, yeah, I am, or no, you're way off base here, right? And then at least I know that's not what we're talking about, and I can keep trying. Some people tend to have a fear that introducing a communication board or a communication device is meant to kind of shut down the verbal language system, and that's not it at all. It's really meant to be a support, so that somebody, if they're really struggling, can point to a picture or write down a word, just to clarify what they mean or kind of reduce frustration. One negative about devices and boards is that they can limit kind of the breadth of language. There's only so many things we can program in or pictures we can think ahead of time that they might want to say. So they're useful for kind of basic needs, kind of general food that they like or medical needs, pain, that kind of thing. But they're not going to be super useful for kind of a random topic, maybe about religion or politics or something. We may not have all the vocabulary plugged into it at that time. So we can have paper versus digital. And then I would just kind of come back to, initially they do feel unnatural to use. We're not used to kind of pulling out a notebook when we're at a restaurant to communicate with somebody. But back to consistency, if we practice and if we just kind of keep going forward and trudging through that discomfort, they do start to feel a little more natural. And so I think you can get there. You just have to be consistent about practicing. I always encourage care partners just to be careful about not quizzing the person with aphasia. I think sometimes there's this inclination to make every moment a therapeutic moment, and that's really not necessary. So just try to avoid things that are quizzes, like, remember I told you that Kathleen is coming over, or even, what time did I say Kathleen is coming over, right? And instead doing something, maybe if there's a memory issue, just at 1:30, you just happen to mention again, oh, I'm really looking forward to having Kathleen come over at 2 o'clock, knowing they may have forgotten, and you're just kind of lovingly and gently reminding them without bringing in embarrassment into the picture. So one big piece about starting with communication strategies in this early stage is that cognition is probably relatively preserved and verbal language is probably pretty preserved. The person can often participate in choosing the strategies they want us to use. So I always ask the person with aphasia, what do you want me to do when you're struggling to come up with the word? Do you want me to give you more time? Do you want me to guess what you're trying to say? Do you want to try 3 times and then I can just cue you to move on so that we avoid frustration? What is helpful? And then I would just say, kind of going back to who is the care partner, those preferences on what the person wants us to do may differ based on the location, right? So maybe at home where there's ample amounts of time, it's give me more time, don't interrupt me. But maybe at a restaurant, it's not worth the frustration. So I'm just going to point to what I want. Would you order for me? But I think especially in that early stage, if we can involve the person with aphasia in helping us understand what they want instead of just assuming we know, that is the best way to go about implementing some of these strategies. And I would always encourage you to start noticing the person with aphasia's body language. Frustration is absolutely going to become a factor here as language gets worse. So often the person with aphasia is highly aware of what their language sounds like and how limiting it is to them. So helping kind of navigate like when the frustration is mounting or it's getting too stressful, and helping them redirect away from that and recognizing like, let's just go take a break and come back to it later. It's so important to remember too that somebody that has any kind of neurodiagnosis, right? That's something happening in their brain. The brain is working harder to do everyday things than it used to. So offer check-ins. Are you doing okay? Do you want to go lay down for 10 minutes? Offer some breaks. Maybe if you're at a party, the break is, Fred, why don't you go sit in the bathroom for 10 minutes and just kind of get away from the noise and the conversation. If the person is able to remember this, you can try to have like a signal for when assistance is needed, like when I pull on my ear, that means like, let's get out of here. This chart is one of my favorite clinical tools. It's technically meant to demonstrate post-traumatic brain injury, cognitive or function and demands. But I think it's really useful for any kind of brain injury or dementia diagnosis. So on the left here, we've got a pie chart that represents a healthy brain. You can see that in general, our brain is being used by cognitive demands, emotional demands, and physical demands at any time. And more than half of the pie chart, or our brain, is preserved as kind of backup juice, backup battery power, right? So if you didn't get very much sleep last night, or you just ran a marathon, right? You can still get dressed. You can still drive your car. You might tap into that reserve though, because your brain is just a little more tired than normal. But with somebody who's got a neurodiagnosis, that reserve gets a lot smaller because those cognitive, physical, and emotional demands, they take up more of the brain power than they used to. So that just like leaves less for the reserve. So if somebody with a PPA diagnosis is at a really crowded party and has a lot of language demands, they might only have an hour's worth of energy before they're ready to crash and they need to go. So kind of trying to figure out, when am I noticing that reserve is just tapped out and we're done here? So before we really pick up those strategies, we're also going to make sure that we think about barriers to using them because they're not going to work for everybody. So maybe somebody has an uncorrected hearing loss and they are unwilling to wear hearing aids. Well, that's going to really affect their comprehension, right? Maybe there's technology literacy. They've never used a smartphone. So I wouldn't suggest that we go straight to an iPad as a communication device. Maybe this person really struggles to receive help from their spouse. And that's just part of their personality and that relationship dynamic. So we're going to try to find things that are more subtle that preserve that relationship. And then also just the cognitive status. We know it's going to change over time. So where are we at today? And is it limiting the ability to learn new things? Do we want to implement strategies that are relatively familiar and not novel to this person? Okay, so the middle stage, you've got all of the ones from the early stage, but we're going to start to kind of narrow down the strategies we're using. So we're going to simplify communication. Instead of this long speech about the weather, we're just going to use go get your blue jacket, right? We're going to speak slower. Again, we've talked about that a little bit. It takes a lot of conscious effort to speak slower, but it can get more natural. Again, with consistency. You're going to find that repeating information is going to be more necessary, offering yes/no questions or choices instead of open-ended questions. So instead of what do you want for lunch today, maybe offering do you want ham or turkey? Or instead just saying, do you want a sandwich? Right? Yes or no. A big piece of communication is attention. So if somebody is inclined to have a cognitive impairment and a comprehension impairment, right, we're going to make sure that we're in the same room as them. The TV is off, the dog's not barking. We have their full attention before we even begin our message. That can really kind of preserve our level of frustration as the communication partner from having to repeat ourselves multiple times, right? Make sure you're doing everything right to set them up well for adequate comprehension. So yeah, don't speak from a separate room, go into the same room. Use visuals to increase comprehension. We talked about that a little bit. Point to what you're talking about, use pictures, use written words. You can continue to use those communication devices as long as that's useful. You can check their understanding. I would make sure that, again, we don't quiz them. We don't make them repeat back what they heard, especially if word finding is difficult. You might benefit from kind of writing something on a sticky note and then handing it to them so that they're not having to store the memory in their brain of what they're looking for. Just go get your blue jacket. Blue jacket is written on the sticky note and they're on their way. And in the middle stage, we really are starting to take more on the communication side of things and anticipate their needs. And in that late stage, strategies are not as useful. We really are at total dependence for communication. The person may not really be able to participate even in the yes/no questions or choosing ham or turkey. Cognitive impairments are present. We're anticipating all needs. They really may not be able to use functional communication to speak or understand. So at this point, again, we're focusing on safety and comfort for sure. Okay, other considerations related to the strategies. Again, every person is different. What works for one person may not work for another. A lot of this is trial and error and involving the person as much as possible to have them tell you what they do and don't like. And I think that takes a lot of openness on the care partner's part too, because the communication partner is putting all this energy and effort into helping communication become successful. So it can be humbling or a little frustrating when somebody says, I don't like when you do that. So it does take kind of stepping back and recognizing, this isn't about me, and it's important that they're able to voice when one of those strategies isn't sitting well with them. We've talked a little bit about cognitive changes, but absolutely as the disease progresses, we're going to see this decline in cognition, which is memory, attention, concentration, planning, safety awareness, speed of processing, executive functions. And executive functions are kind of the ability to organize higher level complex demands. Okay. And especially when we're in the early stage, there are a couple of things that I encourage my patients and their families to do. Start making sure there's a POA in place if that's possible. Make sure a will is organized and the wishes are in there very clearly, and that end of life wishes are talked about. Because as we lose language and cognition, these things are not going to be easy or possible to talk about later on. So talk about them as early as possible. All right, we're just going to wrap it up. I'm going to briefly kind of summarize the different sections we went through, and then we will take questions. So what did we do? We defined the 3 subtypes of PPA. That agrammatic is very halting. You have the apraxia, the motor speech problems. The logopenic PPA is more of that tip of the tongue syndrome, and semantic PPA is more of the comprehension difficulties right off the bat. The various stages of PPA are, right, we've got the early stage, our word finding errors are coming out, language is getting simpler, but cognition is generally intact for the most part. The middle stage, you're starting to see language slow down, comprehension's getting worse, cognition's getting worse. And then that late stage, total dependency for cognition and communication. We talked a little bit about kind of both sides of the coin of losing language. So for the person with aphasia, right, they're losing a big piece of their self-identity, their ability to communicate those ideas and wants and participate in a rich linguistic way in their life. But also for the care partner or the caregiver, it's a very demanding disease on our patients. We weren't maybe ready for someone to become a dependent. It can change the relationship dynamics, and it can cause increased isolation for the person who's doing the caregiving. Our options for speech therapy are really focused on education, creating and practicing compensations, and counseling. Various strategies, I offered you a ton, but for early stage, we really just want to start to kind of simplify that communication and educate others. Don't try to do it all on an island. Bring people in to learn with you. The middle stage, the care partner is taking on more of the language role and navigation. So offering choices versus open-ended questions, yes, no questions, that kind of thing. And then late stage, anticipating all needs and focusing on safety. Other things that could happen with PPA, right, are cognitive decline. And then we want to make sure we're thinking about medical decision making as quickly after a diagnosis as possible, so the person gets to voice their opinions. So there's just a few resources at the end. These are a few organizations that have some wonderful information and support groups about primary progressive aphasia. I've got a few links to communication boards that are free to download. You can try. Oregon Health Sciences University, OHSU, has some really wonderful research about PPA. And they have some wonderful kind of like go-to PDFs that you can even just hand to a neighbor or to a friend to kind of explain what is PPA and what are some of the strategies we can think about. I love the idea of just not having to come up with that all myself every single time. So just kind of handing that PDF over can be a lot easier. Okay, so thank you for your time. It was really a pleasure to be here.
Well done, Stephanie. I particularly like your idea for the early stage about asking the person with aphasia what he or she wants in terms of how they want to be or not want to be helped, especially when you're in front of other people. I think we tend to just step in and take control and not really even think to ask that question, right?
Yeah, absolutely.
Yeah. We do have a few questions in the chat.
Okay.
Some of them were asked, but then I saw that you answered them as your presentation went, so I'm not going to ask those.
Okay.
One is hearing affected by Alzheimer's?
Not that I know of, though having uncorrected hearing loss, so being kind of unwilling to use hearing aids, can make brain function decline, right? So we want to make sure that we're engaging as robustly as we can all 5 senses, wearing glasses, wearing hearing aids, because that activates the brain and keeps it, as active as possible. Mm-hmm.
And is aphasia observed in all dementia or Alzheimer's patients?
I think at some level, yes, depending on the dementia and where it starts. So the dementia gets diagnosed based on the place that it starts in the brain, but all dementias do eventually kind of merge toward the same point, which is language and cognitive loss.
Okay. If someone with dementia simply makes sounds that aren't verbal or clear, how should a caregiver best respond in that situation?
In that case, it sounds like the person with dementia is maybe in the later stages. So I would, at that point with the later stages, we're focusing again on safety and comfort, making sure their needs are met. Those sounds may or may not be intentional communication. Sometimes those behavioral pieces indicate, something's itchy on my skin, or I'm just bothered in general. So trying to kind of look around the environment and figure out what could this sound be related to. I wouldn't necessarily put a ton of stock in it being meant to be a verbal production, though.
Okay. So this one's interesting. I know that there are currently no medicines available to slow the progression of primary progressive aphasia, but I read that antidepressants might be suitable. Any thoughts on that?
I think that's a better question for your medical provider, your medical doctor. I don't know the research, if there's any connected. Sometimes antidepressants can be used to mitigate some of the behaviors associated with dementia, but I don't know if they're specifically related to aphasia in the language loss there.
Okay. And I did see that you posted some links for additional information on the communication devices. Could you speak a little more to that? So if I have an iPad, can I purchase a program or download an app to help with that?
Yeah, there's a variety of options. First and foremost, I would recommend that you seek out a speech therapist to help you find the right one, so you're not just spending $50 here, $100 there on something that may not be appropriate. So there are kind of 2 categories of apps. and devices I would recommend. There's some that offer really just practice with language, which is fantastic. And then there are others that offer more of the communication boards where we can plug in your family members' names, your dog's name, places you like to go, so that the person with aphasia can push a button and say Wendy's via the iPad. There are quite a few companies out there that do that, and so I would get somebody on your team who can help you navigate those.
Can you comment on the timeline or the time frame of the progression? I mean, you have the 3 phases, kind of what to expect. How soon does someone move from phase 1 or the early phase to the late phase?
I wish I could. If you know one person with primary progressive aphasia, you know one person with primary progressive aphasia. It does not move at a standard rate. And that diagnosis doesn't also take into account the other comorbidities that person may be experiencing, like have they had a stroke in their life or some other type of disease that can change the progression. I would say that typically when people get their diagnosis, they are already a year or more into the symptoms. And so you're probably in that like a later early stage. But other than that, is it 2 years? Is it 10 years? It's really variable by person.
And there's no way to slow that progression.
There's no way to slow it. Therapy can choose to focus on trying to preserve really meaningful words like people's names. But it can be hard to choose what words do we want to preserve, right? Language is infinite. That can be difficult.
Okay. There's one more, I think, here. Is there a specific time that you want to bring in a speech therapist? Out of all those stages, should you bring them in as early as possible or wait until a later stage?
Right away. Most neuropsychologists and neurologists, if there's this diagnosis, will recommend that you go see a speech therapist as early as possible. And as the stages progress, you might see the speech therapy less and less because the person's able to participate a little bit less. So at that point, it becomes a little bit more like, maybe once a month, and we're kind of navigating the changes as they come with swallowing, with some of the activities of daily living. It's more focused on that. But in the beginning, we want to set you up as early as possible with some homework programs for language input, training the family and making sure they're really understanding how to use these communication strategies. We're going to do a lot of role play at the beginning and try to figure out what works and what doesn't work for them. So as early as possible, for sure.
Yeah. And you mentioned bringing in the family too. I think that really helps them to stay connected, especially if they have an extended family, if everybody's on board and can be involved. So
Absolutely.
Okay. I think those were all the questions. Since we do have a little bit of time, there was one that was asked early on. This individual said that they have MCI and moderate loss of the anterior right hippocampus and amygdala. What is the difference between that and PPA, or is it all the same?
So MCI, or mild cognitive impairment, is what that stands for. Loss of the anterior right hippocampus and amygdala. What's the difference between that and PPA? Well, MCI is a little bit more focused on the cognitive piece. So you might see with MCI, we're having trouble with memory, especially if the hippocampus is involved. So it's less focused on comprehension and verbalization like aphasia is. And that MCI is probably more focused on kind of getting a schedule correct, tracking a lot of organizational pieces, more of that executive function type of presentation, whereas the PPA is really primarily focused on language. And another difference with MCI and PPA is that PPA, we know, is going to decline over time. MCI, the research does not always say that it leads to dementia. It may just stay stable, and we can often find long-term solutions to kind of support the person with MCI and kind of keep them afloat with some of those memory loss issues or executive function issues. It's not a guarantee that it will turn into dementia, whereas PPA, that's the direction that we're going.
Mm-hmm.
Yeah.
Okay. I think we're done with the questions. Just want to say thank you, Stephanie, for taking the time today to share both your knowledge and your experience with us. It's you've shared a lot of really good information, and hopefully this has helped our audience. Thank you.
So yes, thank you everyone for being here.
Okay. Bye.
Bye-bye.